Okay, good evening. Thanks for tuning in. This is Neil Warshawsky, and welcome to tonight's webinar, where we'll talk a little bit about the micro-osteoperforations, mopping for short, and high-frequency vibrations, and how to get yourself out of a bind when you have tough problems. So, without further ado, let's get started. So, propelling your practice through the turbulent waters. I think that's an appropriate topic with all the Smile Direct Club and Candid Co. and all these other companies starting to come out saying that they can treat cases. So I think it's important to try to establish your brand. So again, my name is Neil. I am an orthodontist. Welcome. I've graduated from the University of Illinois 5 times. I'm an orthodontist. I am also someone who's crazy enough to start my own practice, and I'm so crazy I've done it 4 times. So we have 4 offices in and around Chicago, and I was one of my real loves in school was craniofacial. So I worked at the University of Chicago's craniofacial team till 2006, at which point they discontinued dentistry, and then in 2012 I was asked to. Yeah, actually 2011, I was asked to be part of the University of Illinois, which is where I trained their craniofacial team. So I have headed up orthodontics and the orthognathic surgical program for the craniofacial team at the hospital for the last almost 9 years now. And it's very much a part of my mission to give back. And it's really been it's been a blessing. It's changed and really shaped my entire career. Anyways, since 2007, I've been a key opinion leader for 3M Oral Healthcare. I'm their expert on Incognito, and more recently, I helped them to develop their clear aligner system called Clarity, which you'll see some of these products tonight. In addition, I've been a key opinion leader for Propel since about 2014. So I just work a lot. It's not a bad thing. It keeps me out of trouble. I've been paperless since 2006. I've been cone beam since 2006. We've finished more than 20,000 cases, which is a pretty good sized number. So we've seen our share of stuff. And I am a Cubs fan by genetics, because my office is on Waveland Avenue, which is left field. Okay, so a little bit more about myself. I married my high school girlfriend. I have 3 children. They're all in their 20s at this point. I'm a geek. I'm a Boy Scout. I love to play in the woods. I run, I ski, I swim. I enjoy good barbecue. You know, I'm relatively normal. Okay, so I want to talk about the critical differentiators today, and it really boils down to 2 things. One is your efficiency, because I think people are trying to get your prices down lower, and then second thing is your experience. You know, your experience in terms of how the patient walks out and how they feel about your practice. I think the amount of experience that you bring to the table, you know, and I think these are things that are going to just completely make a difference. So I think you have to really think clearly about treatment plans today, because people shop you, they're going to go on the web, and you really kind of have to, when you talk to people, you have to be on the money and you have to have a bullseye on the first shot. So I like to bring people back and do a second consultation with records when I have a multidisciplinary case. My practice is about 65% adults, so I have an incredible high percentage of surgical and really difficult problems to fix. So, we do a lot of multidisciplinary care. So the way I operate is I do what's called patient-centric care, and I focus on the patient's desires and needs first. And then once I know what their desires and needs are, then I design what they need to have and what makes the most sense. So without further ado, let's talk about these 5 needs. So the first thing we're going to talk about, because that's what tonight's all about, is really speed. Speed to me is a concept that's just intuitive, and yet a lot of people don't get it. If you go faster in treatment, I don't mean be aggressive and be damaging the teeth, but if you're efficient and you can get the teeth to move easier, you're going to make your patient happier, because your patient gets done quicker. They get done quicker, they talk about you. You win because of word of mouth. You also win because your fee's not going to change. So from my end, you're going to make more money. So how we determine how to make the speed of a case go quicker is one of three ways. One is through the design of the appliance. The second is if you have if you modulate the physiology, which is what we're going to talk about. And the third is if you use auxiliaries. So auxiliaries in this case would be like TADs or something. Modulating the physiology could be like what I'm about to show you. So I want to concentrate on this middle section, the modulating physiology, because I think so many people don't really understand this concept. And it's been such an integral part of my practice for more than a decade now, because we've been doing orthodontics and all kinds of stuff, that I think it's really critical. So I break modulating physiology into two ways. One is a patient-controlled non-penetration. So you can either do something like a light generator, such as biopulse, or you can do a vibration such as the vPro Plus here. These are both designed to be used by the patient at home, and it can cost anywhere from a few hundred to $1,000 to buy one of these things. And practically speaking, I think if you get the patient involved, they're oftentimes more likely to be successful, I think, because they're constantly doing something for you. Okay, so down the ladder of aggressiveness, then, if you want to go into a penetration acceleration, we have corticotomies, we have piezo surgery, and then we have the simplest one, which is micro-osteoperforating. So in a corticotomy, it's very invasive. There's a flap. You can add bone or not add bone. It's expensive. Oftentimes, patients have to be sedated. There's follow-up. You have to be really a skilled surgeon to do this stuff, to do it well. Piezo surgery is a little more cowboy in my mind, where you just take a piezo saw and you just cut straight through the gingiva and straight into the bone. I personally don't do this. Maybe you do. It looks gruesome, so I just think that's a hard sell. The micro-osteoperforation that you see here, that's a picture of one of my patients, is really pretty interesting because it's minimally invasive. There's almost no bleeding. It can be done on the fly when you decide to do it. It doesn't take much to do it, and there's really minimal training from your end. So the product that I really like is the product from Propel, the little tips with the motorized drill here. And I think mopping for me is a guaranteed way to make teeth move faster. I think if I want a 1-2 punch, I think to add vibration to a case or light to a case, I think makes a lot of sense. I'm always of the mindset that I want to do whatever I can do to make my teeth move faster and my patient have a better experience. I think when patients see the teeth start to move, what happens oftentimes is they get this thing called blind faith. Suddenly they see a tooth move and they're like, wow, this is great. And then, I keep all of our records online on a server that's operated by Sesame. So we encourage our patients to go online and geek out and see their photos. And every time they come in, if we have time, we take pictures on cases. So typically we take a ton of photos in our practice. But I think this is kind of like just a really effective way to make teeth move faster. So the benefits of the mopping for me is it's really minimally invasive and almost anybody can do it. I don't have to set up chair number 5 to do it. It can be done in any chair. It can be used with aligners. It can be used with braces. It absolutely works. There's no question. Cases move faster with it. I mean, anecdotally, practically, it's been shown in white papers. It's been shown in studies. It cuts the time in closing an extraction site in half in braces. So what's good about it is there's really no recovery time. You got to tell them they're not allowed to have any non-steroidals because this is creating inflammation, and inflammation is what's driving the teeth to move faster. From a patient's perspective, I think they look at this and they kind of think, wow, this is pretty cool. This is really, I've never seen this before. And they think like, wow, you're really smart. You must be on the cutting edge. So it prevents them from getting burned out. And if they're really saying like, I want to be done quickly, you're like, okay, let's do this. You're a part of the solution here. You got to tell me you want me to do this, and then let's do it. So it's really given a little bit of the voice of the consumer to the patient to actually drive the case, and they're actually going to have a little bit of input here in making their own case go faster. So really, why do I like to accelerate cases? I think it's just a smart thing to do. I mean, it literally reduces discomfort once people are past the first day or second of the mopping. If they don't wear the rubber bands, it makes the teeth move easier. If the aligner is poorly tracking, when you mop the case, the teeth move easier, so the tracking will go back on. It'll lessen the number of refinements. It'll practically stop all your patient burnout. If you have a tooth that's being stubborn or doesn't want to move, it'll force it to move simply because you're traumatizing the bone. Any patient who's been previously treated and they relapsed is a high target for me for using mopping or vibration, because I don't want to do to them a second time what failed on the first time. So we're always adding different twists, if you will, to change the physiology, to break the memory, to make the teeth move easier. And I think all these things will lessen relapse. So the more things you throw at them in addition to their mechanics, the better you're going to be in the long run. So, for me, I think that's an important thing. Now, the nature of the biology of why the mopping even works, or why tooth movement works in general, is simply the fact that when you put pressure on a tooth, it causes the osteoclasts to come in and eat the bone on the quote unquote pressure side. When the tooth moves away from the bone, then the blast cells will come in and fill that void and make the bone where the tooth is moved. So when you mop, or you add high frequency or low frequency vibration, or you add like infrared light or any of these things, what you see happen is this whole process just amplifies. It gets more intense. It happens faster. It gets easier. I always tell my patients, if you're doing all this stuff, what's going to happen is the cellular activity around the teeth is just going to sit at the ready and be ready to go, just a lot easier. So from my end, I think this makes a lot of sense. So I don't think it's very hard to do. However, it is not necessarily what you think it is. Mopping isn't about creating the hole. It's about creating compressive stress fracture. So when you put the screw in the bone and you turn that screw, what you're actually doing is you're pushing the bone outwards, and you're actually cracking the bone where the tip is, but then you're pushing the actual physical osteoid outwards away from the thread, which is causing it to actually compress. So you're actually changing the chemistry of the bone, if you will. There are a lot of papers on this. You can look them up in PubMed. You can go on the Propel website. There's lots and lots and lots of papers all about bone biology. So all Propel did was it just took that concept and it narrowed it down to a very specific area. I think learning to do MOPs takes about probably a half hour. It's just not that hard. If you look at this photo, you'll see where the blue arrows are is the area that was just poked, just screwed, if you will. So it really looks pretty good. So this is why I say, it's like, and I'm going to give you a pearl. So this one's worth writing down, which is, for me, after I mop the area, I wipe the area down with chlorhexidine. And I've found that the chlorhexidine actually helps the area to clot a little bit better. So we do it using a syringe from Ultradent, and we very directly put the chlorhexidine in, and we swab the area with chlorhexidine before we drill the area, then we mop it, drill it, whatever you want to call it, and then we redo the chlorhexidine, and that's why these cases look generally pretty clean when we do it. Okay, so that being said, I want to spend the majority of our time now talking about 10 reasons why I think acceleration works, okay? And the way we're going to do this is we're going to review 10 cases. Some cases have more records, some cases have less records. So I'm going to apologize now if you want to see some more records, but it's kind of hard to discuss something quickly and be able to give you a thorough understanding, and then kind of get in and get out and leave room for questions. So So I'm apologizing in advance. Now, before I do this, I want to launch my first poll of the night. So let me just do this really quickly. Okay. So my first poll, here it comes. The poll just opened up, and the poll will be about whether you do MOPs or not. And I'm just kind of curious to know how you guys, if you have any experience in this or not. So I'll kind of keep this open, and we will continue to move forward. Okay, so reason number 10. Why would I use MOPs? Patient has limited time for treatment. So the case I'm going to show you is about looks, comfort, and speed. We're going to do accelerated care for a graduate student with a hybrid appliance. Okay, this is my boy Trevor. He's 28 years old. He has had orthodontics, and as a result of him having orthodontics, he has grown after the fact and gone into a unilateral crossbite, unilateral class 3 on the right side, and he's been told he has to have jaw surgery. So Trevor doesn't want to have jaw surgery. So as a result of that, he came and talked to me, and I said, you know what, I don't think you need to have jaw surgery. Your face isn't that disfigured. You just need to improve your bite, because he wasn't complaining about his looks. So we went ahead. Here's his record. You can see his bonded wires are still in place. Here's his ceph showing his edge-to-edge bite. So my treatment plan was pretty simple. I'm going to jump the cross bite with a Unitek palate expander, and I'm going to mop the buccal segments while that palate expander's in. For the unilateral class 3, I'm going to actually extract a premolar on the lower right, and I'm going to put them in braces for about 4 months, and I'm going to close about 40% of my extraction site, maybe 30%. And after 4 months, I'm going to take the braces off. I'm going to put them into clear aligners, and we're going to wear class 3 elastics, and we're going to see how we do. At bedtime, he's going to vibrate, with a V-Pro Plus. So here's a picture of him with the palate expander just being installed, and you can see the braces on the bottom. That was pre-extraction. And you'll notice when on the top, you'll see the NPE. That's a nighttime palate expander. You get them from Henry Schein. They're actually pretty effective, and I like to use them when we use mopping on the buccal to try to jumpstart my transverse correction. And as a result of that, I will oftentimes, if it's a mild correction, I'll do it this way. If it's a full-blown hardcore correction, I'll do an MSE, a maxillary skeletal expander. So this is what he looked like in treatment. Gave him 4 months. Here he is with the braces off. Now we're taking records for his clear aligner therapy. You can see the extraction site's been reduced some. Here's the Panorax, and I know you'll notice kind of a weird thing. I kept the second bicuspid with the root damage, and I took out the first bicuspid, which had a slightly longer root, but there was no way I was going to be able to get that midline to really correct, get the overbite and the overjet into a positive dimension, if you will, if I would have taken out the second bi, so I would have lost too much anchorage. So that's why I did what I did. So we went ahead here, took some records. You can see that we clearly expanded the maxilla. And at this point, we did a setup. So here's the setup that I'm planning to do. He'll be a solid class 1 on the left. He'll be like a class 3 molar and a class 2 canine on the right if things go well, but he'll fit pretty well. It's a compromised result, but it's a good result, I think. Good plan, I thought. So here he is at stage 18. He was tracking pretty well. I was pretty happy with how things were going. Picture on the left represents what stage 18 is supposed to look like. picture on the right is a progress scan of stage 18 showing that the teeth were tracking, but not tracking perfectly. And it's interesting that they weren't tracking perfectly along the first and second molar on the left side. So I opted to actually rebuild the case at this point. And so this is the 3M system. So in the 3M system, what happens is when you refine or rebuild your case, your next stage is the next number. So the refinement starts at stage 19. It doesn't go back to 1. Here he is at stage 24, and you'll see that his midline is doing pretty well. It's improving nicely. He was already in positive overbite at this point, and this is about his 12-month anniversary. And he's got 36 stages in total, and he's spending about a week per stage. So I'm expecting, about 15, 16 months, I should have this case finished. So the analogy that I always use about stuff is, when presented with a problem, it's no different than if you're in your car. In your car, you would use a piece of software like Waze. You open up your phone, there's a traffic jam coming. You'll see where the problem is, and you'll steer it. So in this case, this software happens to go back up to the cloud, compares your scan to what you should be, comes back, and it's going to suggest how your teeth are doing. It's going to give you a table, and if you learn to read the table, it will tell you exactly what tooth is struggling and how much it's off and stuff like that. So for me, this is great because this is just a different way of thinking, because now it tells me, okay, like in this case, I told you, I changed it at 18 and rebuilt, but if you look now, I'm at stage 24. The overlay models look pretty darn good, and none of these columns are lit up with red numbers, which means that you're greater than 30% off. So there's a couple of red numbers, but the numbers are small in value, so I'm not that worried about it. If you look at his 10-month photographs, you can appreciate how much his front teeth have changed, how much his midline's changed, and that's a significant amount of midline change given that he's a clear aligner case. So, I kind of consider this cheating a little bit because I started in braces, but I think this is what smart mechanics are about. It's about doing what's right for the patient, not necessarily doing what's best for me. That's what he looks like at 12 months, and you can see the button on tooth number 3 because he's wearing class 3 elastics as well on the right side. So he's really doing a pretty good job of everything I had asked of him. So I'm pretty happy with where he's going to end up being at, and I believe that when we get to the end of the case, he should be relatively happy. But that's what he should look like at stage 24. And that's where he's at. So maybe, you can see from the midline that he's a little overcorrected right now. I'm not worried about that because I think that, I took a tooth out on that side. So I expect the midline to go actually a little bit to the right. So that's okay. This was when we went to the refinement, the rebuilding, or whatever you have the case. This is how the case will wrap up. And you can see the video showing the teeth coming into occlusion. Like I said, the canine is going to be a little bit on the class 2 side, but that's okay. I mean, because he'll have positive overbite and overjut, and it just is a pretty stable bite overall, I hope. That's pretty good arch form, given how he's starting. And the blue represents how much his teeth are changing. Okay, so case number 2. A patient's prepping for restorative care. So this is a mom of 4 of my patients in my office, and she didn't really think that she wanted to do orthodontics, but she was having a lot of problems with her teeth. So she was trying to look for a relatively cost-effective solution because she knew she had to get some veneers on her teeth. So I ended up choosing the Clarity product simply because I can control the cost, and it's about, at least at the volume that I buy at, almost $800 less than Invisalign. But it's a pretty good product, I believe. So here's how she started, and you can see her canine was kind of hiked out there on the left side. Midlines were off. I'm not going to try to change the midline. I'm just going to try and make room for the veneer so that when they go to veneer her teeth, they prep her teeth the least amount. So this was her after her attachment was placed, and at that point then we went ahead and treated her with a total of 33 aligners, and it took about 16 months. She was not such a fast person, but that was okay. In terms of did I achieve the goals I was trying to achieve, the answer is yeah. So in this scenario, she was using vibration at night along with her aligners, and she created a nice arch form. That's her after her veneers were done. So this was a pretty conservative case. Only 4 teeth were veneered, which were 7, 8, 9, and 10, and everything else was just well aligned. So did we contain the cost? The answer is yes, we did. Did we make room for those lateral incisors for the veneers? Yes, we did. Did we manage her cosmetic expectations? Yes, we did. So for my end, this is a success. These are the types of cases I want to do continuously. I just want to be able to start a case, follow my path, finish my case, get divorced. Okay, case number 3, failed treatment. Now we all see these. This is a functional relapse, and this is a tough relapse. This is David. David is really interested in trying to improve the health of his teeth. He's had orthodontics done already. He's missing 4 premolars. Here's a better look at his teeth. He's got recession. He does not have a lot of pocketing. His periodontist doesn't want to do anything until his teeth are well aligned. So he was like, what can we do to fix these teeth without having major surgery done? So this is his palate. That's his lower arch. I think you would call those dumped premolars on the lower. So my concern is twofold. One is I've already got damage on a case, so I don't want to make it worse. And then the second thing is I want to manage his expectations, and I'd like to try to do this in a reasonable amount of time. So as I told you early on, I've had a cone beam since 2006. So every one of our cases has cone beams, and you can see the lack of bone on these premolars when we started, and you can see how they're tipped inwards out of occlusion. So from my end, this is what helps me to plan, helps me to understand how I gotta upright teeth, where I should place my attachments, where I should be mopping, if you will. So these teeth were heavily mopped because there was almost no bone around them, and I believe actually if you traumatize the zone to the point that the bone softens to repair itself, the teeth are going to move easier. So you'll see the lack of bone on the premolars on the top there. I mean, really, it's really pretty startling. So when I designed braces for him, David was a little cosmetically vain. He asked for a custom-made brackets. We use a product called Incognito, which is a hidden lingual bracket, which is custom-made. So we wrote an order, and we plan to not do any perio surgery until his ortho was completed. And then we used copper, nickel, titanium arch wires to upright his teeth. So from my end, we were expanding the buckles pretty hard, and we used crisscross elastics to support it. Every 8 to 10 months, he had a cone beam, and we monitored closely with the periodontist the pocketing. So this is what David looks like at the beginning, and he had 2 rounds of MOPs, so that we were probably, I think, probably month 3 and month 6 or 7 is when the mopping was done. I think I failed to mention on my very first case on Trey that he was also mopped twice, and that's in addition to the fact that he's wearing using a VPro Plus at bedtime. So this is David 3 months into his case. He was just starting to upright. Here he's at 8.5 months into the case. You can see the teeth have uprighted significantly. Those are the same teeth that you're looking at on the left and the right. Here he is at 10 months. His teeth have uprighted quite a bit at this point. He's feeling much more confident about his appearance as well as his occlusion. So you can see how much different he looks during a short period of time. The width in the palate is significantly different as well. I blew the picture up, but the white lines were coordinated. So for your purposes, you can see how much of a expansion transversely we did on this case, which was sizable, because all we did was we put braces on this guy and crisscross elastics with a with a fair amount of mopping on the buccal segments to help soften the bone. Here's our lower arch, significantly better, especially on those second bicuspids. And you can see the whole occlusal table on the teeth now. And this was the visit before we took his braces off, where you can see how much expansion we actually achieved. His whole palate remodeled. So in about a 6-month period from month 10 to month 16, he actually started to develop some bone on the buccal of these teeth, which was just really tremendous. So we were really pleased to see that he was responding well, given how much trauma we inflicted on these zones to try to get them to improve. So one of the things I've learned is don't expect to see the bone growth right at the beginning. It takes a little bit of time, but it does happen. So you just have to be patient, and but you gotta be gentle and not to rock the area too hard, disturb it, but you don't have to do craziness with it. So after 17 months, this was his final result. It's not perfect, but very much a good spot for him to see good results from. So this is a good time for me to ask you another poll, which I'll open quickly and close. Sorry about that from the last time. Next poll. Poll is now open, so please vote. Do you charge for MOPs, micro-osteoperforation? And if you do, what do you charge? What's your price range? Is this something that you want to make some money on? Are you just trying to cover your tip? Are you willing to lose money? Is this something that is like a get out of jail card, which will make a difficult case start to do better, do worse? Okay, so it's interesting. Almost 60% of you responding say you don't charge for micro-osteoperforating. I respectfully tell you you're wrong. I think you should charge. I don't care if you charge a lot, but I think you should charge something. We're in the $100 range roughly. That's about, we basically cover the cost of our tip. And I think it's, from an overhead perspective, I have a lot of stuff that I pay for. So, every time you get a box of tips, it's like $2,000. So somehow you got to pay for that box. In addition to that, I think it it literally, if you could close a site and they don't need an implant, if you're going to help them save $4,000 to $6,000, I think at the very least the charge for your equipment is worth it. But I think we spell it out on our contracts, like, you know, if you need this, this is what it costs. We're just matter of fact about it. We don't mark it up. We actually lose a little bit of money on everything we sell, whether it's a vibration device, an infrared device, or a TAD, or a Propel tip. We sell them at a loss to make them affordable. So that's just my belief. All right, so I'm going to close my poll and return back to my slides now. So patient needs to improve his teeth for continued success at work, meaning self-esteem. So this is just a quick thing I want to show you. This is cost, lifestyle, and looks. This guy was becoming a cop and didn't want to have labial braces because he was afraid that people wouldn't take him seriously. So he wanted lingual braces. I think you're going to tell me that this is a pretty difficult palate. 10 years ago, I would call that a surgical case. Then, you know, Propel entered my life, and suddenly we started taking cases like this and fixing them. And that's exactly what we did on this case. This case was expanded through arch wires, rubber bands, and micro-osteoperforation, which was done twice. This was 8 months into the case. We were transversely much more improved. We matched our setup, and ultimately, you know, we're done in about 2 years. The picture all the way on the right is with his 2 crowns and those front teeth done, and that was about 12 months after we finished the case. So this is an old case, actually. It was one of our earlier cases. I show it to you only for you to understand that I think it's important that you actually believe that this stuff works. So I've got this saying, if you don't believe something's going to work, then it's not going to work, and it's just that simple. So don't go into this thinking you're going to fail. Go into this saying you're going to be successful, because that's really what it's going to take for you to do well here. So one of the things we see a lot in a practice that has a lot of adult therapy is camouflage. So I'm going to show you a couple camouflage cases. First one I want to show you is someone who's trying to avoid surgery and get a camouflage. So he actually transferred to me. This guy transferred to me from Israel, where he was going to school, came to the University of Chicago, and his orthodontist in Israel, I had the pleasure of teaching her when I was lecturing in Israel. So she called me up and she said, hey, one of my kids is coming to Chicago. Can you treat him? I said, yeah, sure, it's no problem. So he came in, and this is how he walked in the door. He had a couple tads in between the premolar and the canine on the lower, and then he was already missing buys. And so I didn't really have a whole lot of choice in what happened when he walked in the door. So I just had to be very efficient with my mechanics. So I thought, oh my God, this is crazy, because here's his original Ceph and he's a full underbite. I'm thinking like, oh, that's probably a surgical case for most of us. But, you know, like I said, the teeth were already out and she had put the screws in. So I was just following a treatment plan. So the only thing that I was really concerned about, so this is the Ceph when he walked into my office, and here's the Panorex, was, you know, I had to get these teeth to upright, I had to get all the spaces closed, and that screw was right in between the second bite and the first molar. So I thought, wow, there wasn't a lot of room there. So we went ahead and started to close them, and we did it with a combination of springs and elastics and probably chewing gum and twine. But we were monitoring him closely. We propelled him a couple times. You could see by month 9 at the second propel setting, I was already in positive overbite and overjet. The MOPs really had done their job nicely, but as you see on the left side there, is having a really tough time leveling the buccal segment. So, it was about this time that I took my bite blocks off and continued to close space and extrude the teeth. But you can see how much of a change he had in his face. The picture on the left is how he walked in the door to meet me. The picture on the right was him 9 months into treatment with me. He had really a nice change. So yeah, I think it's I don't always explain this stuff well to patients. I just say I think I need to do this if I'm going to be successful. And most people usually don't find me. Okay, very difficult mechanics. I just want to show you a quick case where I don't think it gets much harder than this. And I think modulating the physiology is effective for tough cases. This woman wanted the best functional bite. She also came in with a bilateral buccal cross bite. She had an anterior open bite. She had 2 ectopic canines. She had moderate to severe crowding in both arches, and she didn't want anything to show. So severe open bite, I think most of us would say that this is just, you're going to earn every penny on this case because it's just a lot of work. And this is our Panorex. So I looked at it and I said to myself, okay, this is probably a 4x extraction case. Oh, and by the way, she's getting married in 10 months. So I don't have to be finished for the wedding, but I have to have things looking good for the wedding. So we ordered braces. In this case, we did lingual because she wanted it hidden. It's going to be a 4x extraction. So we're going to put composite pontics in there to hide the teeth that are missing. She did a combo labial on the lower and lingual on the upper, partly to save money, also partly because she didn't feel her lower teeth showed, so she didn't want to spend the extra $1,000 to hide the lower braces. Month number 2, I did my Propel. So this is literally almost right after she had the teeth pulled. She came in and she had the teeth pulled probably within 24 hours, and then we propelled on top of it. So we just had a whole lot of trauma going on all at once. You'll notice the asymmetrical second bi on the right and a first bi on the left to try to manage our expectations and midlines. Here's the case starting to unfold. You can see that the arch form was pretty good, that she did a nice job of just kind of very slowly growing out of that V-shaped arch form. The canine torque actually reduced tremendously simply by me tying a steel wire along the tooth and pulling the tooth inwards and downwards. So the torque was almost fully corrected just by the time the tooth landed. So and I didn't even have the braces on yet. So I got the braces on about 3 months before the wedding. So here's the teeth still coming in. You can appreciate that at this point, I got a scanner to get that left canine bracket built. So both brackets were on by month number 8. I built them one at a time. And this was about the time that she had to get married. So by month number 11, you can see that we were pretty much in control on the case, and the case was resolving nicely. Midlines were pretty good. By month number 20, I was just working on finishing my midline and closing my bite. But most of my open bites were closed at this point, which was really tremendous. And here she is finished. So you can see the start picture on the left, the finished picture in the middle, the proposed setup on the right. So I think, this is really a nice finish for somebody. She's a beautiful girl. She's got a really nice smile. She's got good dental show. And I don't think I could have done this without the Propel. This is interesting. We all have these where kids grow a lot. Here's a case where this is our friend's son. Someone else did the ortho and did a nice job taking records, and we can see that the records on this kid as he was growing. He ended up having a phase 1 that concluded almost 2.5 years after it started. So his phase 1 took almost 4 years. I'm sorry. It was a really long phase 1. They had a hard time controlling his growth because he was growing a little asymmetrically. They got him somewhat back in line and then did a quick phase 2 on him. So he was done, I want to say somewhere around 13, 14 years old. And then he grew. So these are not my records. Those are my records. In January of 18, he walked in the door with a unilateral full crossbite to the left side, midlines off by 3 millimeters, and an anterior open bite. So I looked at him and he's like, "Uncle Neil, what should I do?" I'm like, "Sleep on your face." No, just kidding. So I looked at him and I said, we can try and treat you, but from a practical standpoint, you may still be growing, but he was starting to have headaches and he was going to Michigan for college and he really wanted to get everything kind of wrapped up for college. So I said, okay, so I believe in always treating my worst dimension first. So I don't know what you would do, but I decided my chief complaint was he was in pain, so I thought I'm going to get rid of this crossbite because he didn't want to do orthodontic surgery. He wouldn't take out any teeth, and he was willing to do anything else. So I thought my treatment plan is going to involve a palate expander. So I went in there and I did a full-on Hyrax. He's about 18 and a half when we did it, and we mopped him in addition to try to get extra expansion. We definitely got a suture to pop open. His mom was freaking out, thinking like, "Oh my God, you broke my son," which I thought was funny. You can see that we got him nicely open. He really did a good job on the expansion. He did 4 turns a day. He was very motivated because he wanted to get fixed. So we took the expander out a month later, did records. So April 2nd, we took records for his clear aligners. We delivered them on May 21st. We had 16 total aligners plus elastics. So he wore over about a 16-week period, not even a 16-week period. He went from May 2nd to August 13th. He wore aligners plus he used a high frequency V Pro Plus, and we went ahead and we started to expand him further. We did some IPR. We wore class 3 elastics. We further expanded him, and it's not going to be a perfect fit, but given that he was a full unilateral crossbite, by August 14th, that's a pretty reasonable result. He's still class 3-ish on the right side, but he was a pretty solid class 1 on the left. So he literally left from my office and drove straight to college because they were moving him in that day. So we had glued in wires both top and bottom, and the entire treatment plan, which was definitely kind of a weird treatment plan, but his entire treatment plan was 8.5 months. So there's a question that says, where's the location of the MOPs when we expand on an adult? And it's usually always for me going to be in the same spot. I'm always going for like the first molar from the distal of the canine to the first molar. And I tend to do 2 to 3 MOPs in between the teeth to make sure that I can get the bone soft enough to kind of stretch. So that was my predicted setup, and that's what I actually achieved. So I think it's pretty close. I mean, it's not bad. I would love to see it a little bit better, but hey, you know, considering he got the aligners May 21st and he was done by August 13th, I think, you know, for 3 months of wear, nobody can complain because we were switching the aligners every 5 days towards the end. This is a fun one. I'll just call her Bridezilla. She was actually super sweet. I'm running out of time, so I'm just going to go through the case quickly. I've shown this case once or twice, but I show it for the right reasons. She walked in our office and she was getting married in 93 days, and she had a pretty healthy space. We talked about cutting the teeth, we talked about bonding the teeth, and none of that really helped her. So we ended up putting her in braces. And one of the things I told her was, if you're going to do the braces, you have to propel the very first day, and you're going to have to propel again, like, you know, like 30 to 50 days later. So I think we did it about 50 days later. There was a question about, do I do lingual MOPs on my expansion cases? And the answer is I don't. I don't feel the need. I just put the MOP in as deep as I can from the buccal, and that's all the trauma that I need to get expansion. So in this case, we put the braces on. You can see the positioning of the brackets. These are innovations. So I'm going to use I'm generally a self-ligating practice, so I'm going to use self-ligation so there's a little less friction. So this is what she looks like on the day we installed. This is what she looked like on week number 8. She already was pretty level by then, which was pretty impressive, I think. That's my 10-week change, which is pretty good. Here's the MOPs at week number 10. So day 70, I guess. Sorry about that. I was close with my guess. You can see the little red dots. It's not too horrible. Here's what she looked like debonded for the wedding. There's no bonding on her teeth. There's no cutting of her teeth. I did, however, bond a wire on the lingual of her teeth. And then I put her into clarity aligners after the fact to kind of finish the case, but that was like a year and a half later. So this is what she looked like before the wedding on the left. How I finished her for the wedding is on the right, and in the middle is what I actually did. Once the wedding was completed, I kind of cleaned her up and tweaked her a little bit with some aligners, because at that point it wasn't a hard case, and I actually didn't expect her to show back up, but I was tickled when she walked back in the door. I thought that was kind of funny. So this is a really nice change for a really short period of time. Okay, so 2 more cases to go, coming to the end. Talk about messed up. Here we go. This guy's a Brody bite. I don't know if you ever see cases like this. He took 3 years to start with me because he wasn't sure he needed braces. Do you believe that? Look at this case. This case is crazy. Here's his Ceph. Here, and I'll get to your question in a minute. Here's his Ceph showing you he's literally pushing his lower teeth out of his jaw, right? Horrible bite. And this is just such a hard case. Like, I didn't even know how to approach it. So you're going to see what I did, but this is the shape of the arch form that I was able to just in progress. You can see how much the right buccal segment has uprighted. These teeth uprighted almost like 25 degrees. And now we're closing all this excess space. And I mop this guy about every 3 to 4 months. And I mean, like, I brutalize this guy because this guy has so much excess bone, I just don't know what to do. This is the change in his Ceph so far. So I fully suspect that I'm going to get him into a normal overbite before it's all said and done. So I think you see stuff like this, and it's just so ridiculously hard to treat that I'm like, I don't know what to do. So, you just have to have something like this, like Propel or vibration or something in your bag of tricks, because these are just not normal cases. Last case I'll show you, number one reason. It's hard problems are just hard to treat. So I don't know if you can see this case fully, but this is a fully double impacted canine case where both canines were severely impacted. We had both teeth exposed. They came in one at a time. Because the teeth were so impacted, she started to open up vertically. So then I used Propel in this case on the buccal of the teeth so that when we wore vertical elastics, just to keep the whole maxillary arch kind of irritated and to keep vertical pressure on the case so I can eventually close the case down. So interestingly, she tells me last summer, we're moving to Minnesota. So I said, okay, fine, I'm going to transfer you to someone in Minnesota. So she had lingual braces on. So at the time, she was in good shape, but she had lingual on. So she's getting like $6,000, $7,000, $8,000 quotes to finish her case. And I looked at her, I'm like, my whole case was $8,000. Why is this so much money? So I just said, you know what? I'm like, I'll put your braces on the outside. I'll see you 2 more times. Just show up like every 3 months and we'll wrap you up. So the picture all the way to the left on the top will actually show you that, in fact, her teeth are fully in. Her occlusion looks great. She's fully class 1. It's all really, really good. So just is what it is. So I think, for me, one of the big lessons I've learned is that acceleration is not a sin, and a lot of people don't even do it, which I'm thankful for because it sets me apart. But I do this patient-centric philosophy where I ask patients what they want, and I try to design treatment plans that make a lot of sense, right? And I think when you do that, it's easy to implement, it's affordable to the patient, and ultimately, patients are able to achieve goals that are really not achievable unless you're an out-of-the-box thinking type of person. So, I think if you learn to incorporate ideas like this, and I don't care whether you do it a lot or infrequently, just the fact that you can use it makes your practice unique so that other people can't touch you. And I think setting yourself up for success is about being confident and being able to deliver mechanics that make sense. So if you have further questions, here's my email. I'm happy to share my email with you, and you can always shoot me a question. It's not a big deal. It's all good. Last thing I want to do is I got one more little poll for you, and that will be this. I just launched it, and it's, do you use the vibration device in your practice? So I'm just kind of curious to see who uses it and who doesn't. And it's arguable information. There's been a lot of back and forth about whether it works or it doesn't work. This is very interesting. So our results show right down the middle. 50% of us use it, and 50% of us don't. So, okay. So again, I'll tell you just another pearl, which from my end is, I think I sell those devices at a loss because I want people to understand that I'm buying into their therapy. Meaning, if you want to do this, I'm like, I'll eat some money to make it happen. Because if you finish faster, I make more money. I don't say that, but that's the truth. And I think a lot of people appreciate that. They don't always say that, but they do start when when you kind of mature a little bit in your practice and you start looking at your numbers. because you're just trying to figure out, what can you do to be more effective and more efficient. These types of things work really well. All right, so it's 8 o'clock, and I promised I'd finish on time, and everyone's been very attentive, and no one dropped off, so I really appreciate that. I hope this was interesting. I hope my cases were thought-provoking, a little out of the realm of normal, but they can walk in your door too. So I think it's what I love about orthodontics is many things I love about orthodontics, but one of the biggest things I've seen time after time again is that people are willing to help each other, and it's just not a catty thing. So I think from my end, it's fun to do these webinars. And okay, so again, thank you so much. I really appreciate everyone tuning in, and look forward to maybe seeing you at a meeting or in person somewhere else. All right, take care. Good night.